Good afternoon, everybody. We are here from Reno at the Project ECHO. I'm Dr. Umanga Sarma. I'm one of the geriatricians. I work at Sanford Center for Aging. Today, I'm going to introduce to you our presenter of the topic, Dr. Baltar. So it's over to you, Dr. Baltar.
Thank you. Thanks for having me. So I was given a case before this presentation, and it was submitted by Maureen Choman, and I'm wondering if she is here right now, if you can tell us a little bit about yourself.
Hi, can you hear me?
Yeah.
Okay, I'm Maureen. I'm a third-year medical student. I'm doing my internal rotation out in Elko right now.
Okay, great. So if it's okay with you, I'd like to summarize the case that you submitted.
Sure.
And then address the questions that you had. So you have a 65-year-old male. He's got a past medical history of end-stage renal disease, diabetes, anemia of chronic disease, and it looks like he had a significant weight loss. That he was 180 pounds in May and went all the way down to 133. And what you noted was that he has dentures. He decided that he was not going to get them readjusted. They put him on a soft diet, and he had a worsening of his weight loss. And your question was, how is this managed? And well, to answer your question more thoroughly, this is something that I'm going to cover through the course of my presentation, but comprehensive history is important for this kind of case. Whether or not he had depression, why did he not want his dentures readjusted? Is there, when he was changed to a soft diet, is there a component of dysphagia that would require a gastroenterologist intervention or workup? What other aspects of his medical history or his medication list would lead to certain aspects of malnutrition or possibly worse than that? Another question that you mentioned was his diet restrictions. So actually, I'm really glad you asked that question along with the question about Megace, an appetite stimulant, because I am also going to address that later on in my presentation, and I'll be sure to alert you when I do go over that slide. But dietary restrictions are, they have been looked at in the elderly population, specifically in the nursing home setting, and I'll give you a little bit of data on that as we go along. But with that being said, I'm going to go ahead and get started at the beginning here. So I'm going to be addressing malnutrition of the older adult, and I've entitled my presentation, Eat Well, Be Well. And a couple of learning objectives that I hope you will gain from this lecture today is, number one, be able to explain the importance of diagnosing malnutrition in the older adults. Number two, being able to utilize the most recent consensus statement that's been developed by the Academy of Nutrition and Dietetics along with the American Society of Parenteral and Enteral Nutrition regarding the diagnosis of malnutrition. Number three, be able to identify those modifiable causes so that we can address and treat them. And then finally, incorporate current data regarding the use of supplementation and orexigenic or appetite stimulants, as Maureen mentioned in her question and case presentation. And then we can use that towards our clinical decision making. So I included some data here that was published in the Journal of Parenteral and Enteral Nutrition in 2014, and they were looking at the economic burden of community-based disease-associated malnutrition in the U.S., and they found that it was approximately $157 billion spent a year. And the reason for that being is that about 3 million older adults are affected by undernutrition. And when that happens, 3 million older adults have associated functional decline, decreased quality of life, prolonged hospital stay, frequent hospital readmission. You can imagine how much things like this would cost. And what's important for us clinicians to know is that many of these causes of malnutrition are related to modifiable factors that we can potentially treat and intervene with and prevent this process from happening. But first, I wanted to define malnutrition. So malnutrition can occur along a continuum, and that continuum has a number of different factors. Why does it happen in an older adult? as we age, we get things like impaired absorption, altered transport, altered nutrient utilization, and increased requirements, along with inadequate intake that is observable by the clinician. So you can, there are ways to assess whether or not somebody is getting the adequate nutrition that they need using tools that I'm going to explain later that are involved in the consensus statement that's been developed. And it's also important to know that weight loss can occur during at multiple points along this continuum, giving us clinicians the opportunity to identify and intervene along this process. And this is just further highlighting the importance of diagnosing malnutrition. So each one of these bullet points was taken from a paper that discusses each one of these ailments and its association with malnutrition. And if you look at a couple of these bullet points, these are very common geriatric syndromes: pressure ulcers, delirium, physical and cognitive decline. And each of these papers have been published in the last 5 years or so in the Journal of American Geriatric Society. So just some more points to further emphasize the importance of being able to diagnose this. Now, one of the simplest screening tools that we use in almost every setting, in the hospital, the clinic, the skilled nursing facility, is serial measurements. And that is going to clue us in as to whether or not there's a problem. But in order to do that, you have to know what clinically significant weight loss is. And as defined by the minimum data set, usually used in long-term care facilities, it's 5% decrease in baseline body weight in 1 month, or 10% in 6 months. And the consensus statement uses slightly different significant weight loss parameters, but I will go over that in just a minute. Now, this excerpt is actually taken from an article that was published before the consensus statement was developed. And the problem at that time was that the current approaches back then to the diagnosis of malnutrition were so variable. And there was generally poor sensitivity, specificity, and inter-observer reliability among the current protocols that were in place at that time. So that lack of standardization ended up leading to a lot of widespread confusion and potential misdiagnosis. Hence them coming up with the consensus statement that was developed in 2012 by these two Academy of Nutrition and Dietetics and American Society of Parenteral and Enteral Nutrition. And what they came up with was 6 clinical characteristics. And of these 6 clinical characteristics, 2 are needed to make the diagnosis. And before I go into the table that I've provided as a handout for you, it was a table adapted by those two, from the actual consensus statement. But first I wanted to go over what estimated energy requirement is. And this is a formula which you don't have to memorize, because you can simply go on Google and put estimated energy requirement calculator, and then you'll get something where you can kind of just input your patient's objective data. But basically it's a calculation that accounts for gender, age, physical activity, weight, and height. And what PAC stands for is physical activity coefficient. And there's a different coefficient that applies to a sedentary all the way to active individual. And once you've calculated your EER, then you know the caloric requirement per day of your patient, and then you can determine from that how much of that EER are they actually consuming in a day. And then that will play into your diagnosis. So we can switch over to the table, and this is the table that you have available to you. And this was a table that I built, and it was adapted from the consensus statement. Okay, and it basically includes all 6 clinical characteristics, and you can see that on the left-hand side. So energy intake, so you calculate your EER, and if you notice there are 3 different columns, and each column you would need to categorize your patient into one of the 3 columns. Malnutrition in the setting of an acute disease defined as 3 months or less. Malnutrition in the setting of chronic disease, of course, that's going to be 3 months or more, and then starvation related. And what that is, in the absence of disease, your malnutrition is secondary to either a community or a social aspect. So just focusing on that first column of acute disease, energy intake, after you've calculated your EER, you then determine what percentage of that EER they are actually consuming. And if it's less than 75% over 7 days, then that's classified as non-severe or moderate malnutrition. And then less than 50% over 5 days would be considered severe. And just moving down the list here, interpretation of weight loss, we always look at our serial weight loss over time. So again, you would classify your non-severe moderate versus severe based on the percentage of weight loss over a given amount of time. A new thing that dietitians in the skilled nursing facility at the VA, for example, are starting to incorporate into their assessment is a physical exam. And that's relatively new. So they assess things like body fat loss. So they have to look at things, physical features maybe around the orbital bone, the triceps, or fat overlying the ribs, and then classify whether it's mild to moderate. And then muscle mass loss, looking at the temples for temporal wasting is a good way to assess that. And then fluid accumulation. The reason that that's included is because edema or fluid accumulation can mask weight loss. And sometimes we'll have patients that have high BMIs. They'll have a BMI over 31, but that does not necessarily mean that they can't be malnourished. So that's an important consideration to have. And then finally, there's grip strength, and that's assessed by a measuring tool, a dynamometer, and each manufacturer has a normal value established for gender and age, and you would use that to determine whether or not their grip strength is measurably reduced or not. So we can go back to the case. I wanted to include a case discussion just to tie all these things together and then move us into the portion of the lecture about treatment and intervention. So this case discussion is a 68-year-old male. He was admitted to the skilled nursing facility for acute rehabilitation after a right femur fracture and a total hip replacement. And his hospital course was complicated by a prosthesis infection, sepsis, requiring IV antibiotics. And the reason he had this prosthesis infection is because he has a history of rheumatoid arthritis and was on a number of immunosuppressing agents. And these were his outpatient medications. And the reason I included this slide is because a number of medications can affect the ability to maintain adequate input for various reasons. For example, loop diuretics. He was on Lasix for an acute renal failure, and that can cause dry mouth. He had complained of appetite suppression, and if you can see there, he's on some opioids that can cause that. He had some complaints of dysphagia. He was on IV doxycycline. He was on iron supplementation, NSAIDs, and potassium supplementation because he was on the Lasix. So all of these things can contribute to complaints of dysphagia. He also had some nausea and vomiting, which could be induced by the amitriptyline for his depression. So medication review is very important in your assessment of malnutrition and making sure that none of those, that if any of them can be stopped, then that would be one of the interventions that we can potentially do. So he complained of poor appetite, as I said, and a 35-pound unintended weight loss. And this is pretty significant. So he's already met one of our clinical characteristics on our diagnostic tool. I've included some objective data here so you can calculate an EER. So based on a weight of 102 kilos and a height of 190 centimeters in a male, his EER, he was also sedentary because he had just had that hip fracture. His EER is 2,600 kcals per day. Per dietary documentation, he was only really consuming 50% of that EER and sometimes less, and that was over the course of several weeks. So he met already 2 of our clinical characteristics and definitely meets that diagnosis of malnutrition. So how do we intervene? And this is going to touch on the question that Maureen asked in her case presentation. So this is a mnemonic that was brought up to me by one of my attendings, and she, this was published in a Canadian journal actually in 2005, and this mnemonic helps us to determine the reversible causes of weight loss and make sure that we address these things in our workup. So medications such as digoxin, falafel, theophylline, SSRIs, and antibiotics can be medications that can contribute to poor appetite. Emotional, is your patient depressed? Are they anxious? These are things that can decrease the motivation to even want to eat. Alcoholism or abuse, late life paranoia, bereavement, swallowing problems, oral factors. Are they missing any teeth? Do they need dentures? Do they have a dry mouth? Nosocomial infections like tuberculosis can cause problems as well. Wandering or any other dementia-related conditions that can affect whether or not they even remember to eat. Hyperthyroidism, hypercalcemia, hypoadrenalism, enteral problems. Do they have any esophageal strictures, esophageal strictures or gluten enteropathies? Do they have any eating problems, low salt or cholesterol? And social isolation is a big one in an elderly patient. And some of our simple solutions, as I mentioned earlier, I was going to address the use of dietary restrictions in elderly patients. And I wanted to bring up one paper that was addressing that. It was published in 2006 in a geriatrics journal. And what they determined, they were looking at actually diabetes. So diabetic dietary restrictions specifically, and they found that there was little evidence that dietary restrictions improve outcomes. In fact, fewer dietary restrictions may be appropriate and lead to lower treatment burdens for nursing home residents with diabetes. But your case presentation, Maureen, is a patient who has end-stage renal disease, and they were on a renal diet. And when that is the case, you really want to be careful with those people that are on hemodialysis, because electrolytes are affected by their intake, and the dialysate that they use would vary depending on what their levels are. So it's important to collaborate with your nephrologist and make sure that whatever changes you are making to the diet is not going to be affecting their hemodialysis. So in that situation, it's a little bit more complicated, but in the case of general dietary restrictions, specifically for diabetics, maybe in a nursing home or a hospital setting, it has been shown in some studies to lift those dietary restrictions and have better outcomes, specifically in somebody who's malnourished. Other simple solutions, feeding and shopping assistance. People that are in the community, do they have that kind of assistance, and do they need it? Do they have access to it? Individual preferences. There are people that may be going to a nursing home and they're served all of the same foods, but they might have some ethnic or region preferences that are preventing them from wanting to take in more food. And I was given a resource by another one of my attendings with the United States Department of Agriculture website, and it's called choosemyplate.gov. And this is a great resource to refer to any of your patients. It's a user-friendly website, and there is one page that's specifically geared towards older adults. So that's something that can be looked at and used. So what about the role of nutritional supplementation? And I am going to talk about megace eventually, but first I wanted to talk about multivitamins, because this topic remains still very controversial, and purchases were up to $36.7 billion in 2014. So this is a big business here, and it's important to know what effect it actually has, whether there's any benefit and whether there's any harm to using it routinely. So this is not to say this is not referring to patients that have a nutritional deficiency, but just routine use. And one of the studies that I want to point out is the Iowa Women's Study, and this is a relatively new study that was looking at older women that were using vitamin and mineral supplements, and they found that it was associated with an increased total mortality risk, with the strongest association was with supplemental iron. But what they didn't account for is the mortality being secondary to the disease for which iron supplementation was given. So, but nonetheless, B6, folic acid, magnesium, zinc, copper, and iron were among those those elements that were leading to a stronger mortality. And the one supplement that did not was calcium. But there is still conflicting data. And so what's the consensus regarding multivitamins? There's no indication for the use of routine supplementation with multivitamins to reduce infections specifically or prevent chronic disease. And there's little justification for general and widespread use of dietary supplements, unless you have a strong medically based case, such as symptomatic nutrient deficiency. And the reason for that was because they were finding that those who were supplementing with multivitamins were actually exceeding the tolerable upper limit of normal. So this could have been the reason that they were having negative side effects. And what about vitamin D? So half of older adults in the US with hip fractures are considered to be vitamin D deficient. And across the board, vitamin D has been shown to be beneficial. The recommended concentration, as per the American Geriatric Society guidelines, is 30, but other sources may say more. But vitamin D is one of the good ones. As far as Orexigenics, and this is where I wanted to address your question, Maureen, with your case. So Megase, even though it can potentially increase prealbumin in the recently hospitalized patients, the problem with it is that at higher doses, it can cause cortisol suppression. Cortisol suppression that can actually persist after discontinuation of the Megase. And this is a problem because cortisol suppression or adrenal insufficiency can lead to a number of devastating symptoms that can exacerbate functional decline. So you have elderly people who can become hypotensive. They feel weak, lethargic. They may even have an altered mental status and making them less physically active and decrease their functional capacity and quality of life. So cortisol suppression is a big deal, and we don't want to induce it with a medication. Another thing that I wanted to point out about Megase was that some elderly people were placed into this study. They had already been diagnosed with frailty, and they underwent a high-intensity progressive resistance muscle training program. And they found that those that were on Megase they had less muscle strength and functional performance gains. So to add to that, Megase has also been added to the Beers criteria list in 2015 due to its adverse effects. So you have to be careful with elderly people who have CHF. It can impair, as I said earlier, the corticoadrenal axis and also increase the risk of DVT. So that's important to know before starting that medication. And actually, it's recommended against in anybody over the age of 65. So with all of that said, some take-home points. Number one, a consensus statement is available for us to use to diagnose malnutrition, to address the modifiable causes in the older adult, because this is going to potentially prevent a lot of geriatric syndromes. And number three, there's inadequate data to really demonstrate the benefit of routine vitamin and mineral supplementation in the absence of nutritional deficiency. And then finally, appetite stimulant medication has been shown to cause more harm than benefit, which is why you can get more benefit out of taking a very thorough history and really getting to the bottom of why your patient is malnourished. There are so many different things that we can do in terms of intervention that don't include medication and to improve their intake. So does anyone have any questions or comments or any cases that they want to bring up on this topic?
I did just have another question about my patient. Yeah. I don't know if you can speak about it, but he was considering medical marijuana as an appetite stimulant. I didn't know if you had any advice on that or. So
marijuana can have negative effects on somebody with dementia, and I don't know if Dr. Sharma, you want to
except for HIV, I don't think it's recommended for weight loss right now as of the new recommendations, except for SIV when you would use 2.5 milligrams BID, but for other diagnosis, we don't have any current recommendations to use marijuana.
Okay. And then you talked about it a little bit, and I don't know if you can make a blanket statement about it at all, but balancing the dietary restrictions with just strictly caloric intake. So at the last appointment, or at the last time my patient presented, the dietitian recommended he stop the renal diet, stop adhering to the diabetic diet, and just strictly focus on caloric intake. Is there a specific point where you make that decision, or what kind of criteria plays into making that decision?
Yeah, so there have been studies that have shown benefit to stopping dietary restrictions, specifically in a malnourished elderly patient. They have shown that. The studies that I saw were specific to the diabetic diet and lifting that dietary restriction. I'm a little hesitant to mess with the renal diet because I know in somebody who is on hemodialysis specifically, you start messing with electrolytes and then you get in fights with the nephrologist. So you want to be careful in somebody who's specifically on hemodialysis, but anything short of that, I think more data is in favor of lifting dietary restrictions in the malnourished.
Yeah, and again, the thing comes back to the goals of discussion. With somebody who started on dialysis, you're looking at life expectancy about 3 or 4 years, and a person who has so many medical comorbidities already, you should, be looking at the patient too and establishing what his goals of care are. So if he wants to be able to eat more, enjoy his life, I think we should be leaning towards lifting the dietary restrictions. And again, I know there's one question that, there's one of the concern that's not answered till now about the dentures. With people, what we found out is those who have dentures versus those who do not have dentures, it does not actually make much improvement if we put him back on dentures, because the way dentures help is providing more variety of diet, around what you'd expect if you get the dentures in somebody who does not have is around 15% improvement on what kind of variety of food he eats, rather than increasing for the weight. It helps more for them to be able to choose a lot of variety of foods, able to masticate more, chew their food better, and cosmetically. So if I were you or I was the doctor taking care of this patient, I would not favor so much for the dentures. It might be a lot of cost issues because dentures are not covered by Medicare, and less than 10% of private insurance have any dental coverage. So it's a big cost issue, and having the patient who's been gone to dentist at least twice to fit, I don't know it makes much sense for him to push going back to dentist anymore, rather than focus on the type of diet that he can eat. And what we're talking about is I know there's a lot of we're talking about the food preferences in here and what the patient can eat, but there could be other options, like maybe taking more soft egg for the diet and focusing more on the chicken and fish on the protein intake, rather than putting the dentures back on. So for the dentures, I wouldn't push that much for the patient to go back to the dentist, but rather than work on the dietary preferences and see how we can include more protein and more calorie in the diet.
Okay, thank you.
Thank you.
Do we have any other questions, any other cases that we want to discuss?
No?
Okay, that's it.
Well, thank you so much for tuning in.
All right, you all have a wonderful day. Thank you so much.